All right, so today's topic of discussion is going to be asthma. First, we're going to discuss what exactly asthma is. We're going to talk about a few different types of asthma, and then we're going to dig into how I, as an athletic trainer, would handle my athletes having asthma, how I would look out for them, and how they should also communicate properly with me in order to create a safe setting during their training and during their competitive experience. So, first things first, according to the American Academy of Allergy, Asthma, and Immunology, asthma is a disease involving the airways in the lungs. These airways or bronchial tubes allow air to come in and out of the lungs. Asthma affects your airways. It causes the airways to be inflamed. They become swollen over time, and they can tighten, causing symptoms such as coughing, wheezing, shortness of breath, and or chest tightness. We commonly see that in the sports domain when an athlete is working in their competitive setting. They're working up a high heart rate, and that is commonly the exertional asthma, which we're going to talk about in a little bit. And we start to see them gasping for air, their heart rate increases, and they seem like they're in distress. So, like we were talking about, we were discussing exertional asthma. Exertional asthma, also known as EIB, which stands for exercise-induced bronchoconstriction. This is the most common form of asthma that we see within the athletic domain. In fact, it accounts for 70 to 90% of all asthma cases. What we talked about earlier with those symptoms such as coughing and wheezing, we'll see that occur during an exercise setting or during competition. And that's typically when we have that wheezing, coughing, that sign of distress from our athletes. Then they typically need an inhaler for. Other forms of asthma include chronic asthma, which has to do with the chronic inflammation of the airways, such as the bronchial tubes or the lungs. We have aspirin-induced asthma, which on the name as aspirin has to do with symptoms that are triggered due to the use of NSAID, such as aspirin. And then we have nocturnal asthma, which, essence on the name nocturnal, are symptoms are triggered during the sleep, causing difficulties sleeping. So, unfortunately, asthma isn't like any other injury we see in the athletic setting. It's not something that we will diagnose and then rehab, and it'll just get better all of a sudden. Now, over time, we can condition it, the lungs, and can make it better over time, but it's not something that's just going to go away, especially quickly. So, some things that I will do as an athletic trainer to make sure that our athlete is safe and that I can act efficiently and effectively for my athlete. First and foremost, during that pre-examination phase, before the season begins, I want to make sure I know which athletes have asthma. So that's on the responsibility of the athlete and the parent to make sure that they mark in that box and explain the symptoms and what type of asthma they have, along with their inhaler. On top of that, I would ask that the athletes supply a secondary inhaler. That way I can keep that in my office or in my kit if I'm out at the court or the field or the track, wherever the athlete is, in case they don't have it on hand, so I can properly take care of any situation that presents itself in the case of distress. So some responsibilities on my half. It is my responsibility that I want to make sure that I obtain that inhaler, keep that on hand, so I have that in case one of my athletes starts to have an asthma attack. It needs that at their ready. It is also my responsibility to make sure that it's the proper dose and it is the proper inhaler for that specific athlete, and that their inhaler has enough in in its capacity to be able to get its intended use. When it's getting low, I will communicate with the parents and the athlete to make sure that I can get another inhaler on hand, so that way it is on hand and ready to be used in the case of emergency. So another tool I'm also going to use throughout the athletic season is at the beginning of the season, I'm going to take a peak flow meter read for all my athletes that have said that they have asthma. And simple as that, they basically blow into what looks to be a breathalyzer, and there's a meter on it that says what their maximum output is. And then I will record that. I'll typically have them do that about 3 times and take the highest one of that. And then during the season, if they're having difficulties breathing or whatnot, I will then pull out that peak flow meter again and have them blow for another read. and I will use a scale of red, yellow, and green. Of those scales, 80 to 100% is the green category. That means if they're within 80 to 100%, our athlete is good to go. They may need a break or two, but other than that, lungs look good and they are ready to participate when they feel they are ready. Then once we drop under 80, we have yellow, which is 50 to 80%, and that's when we begin to become more cautious and trying to sideline our athlete and making sure that they are okay. And then at that point, we're probably going to have to refer our athlete to make sure that their asthma isn't getting worse, or if they need to do anything else to combat their asthma / get a better inhaler or go through therapy such as corticosteroids, which we will talk about in a little bit. Also, going back to how we talked about the pre-participation exam and writing on there that our athletes have asthma, on top of saying that they have asthma, it would be it's very effective if the athlete is able to explain what exactly is their trigger, so that way we're aware of it and we can treat properly. Alright, so finally we're going to wrap things up with how we're going to handle asthma. So the first one is going to be the acute asthma attack, which is most commonly seen in the athletic setting. That's when those quick trigger symptoms start to come up, the coughing, wheezing, signs of distress, and how we're going to combat that. As an athletic trainer, like I said, I'll have the inhaler. That'll be consisting of what's in that inhaler is a B2 agonist. The most common form of that is albuterol. That was the prescription medication name on the inhaler. That inhaler will be used in acute setting, and it will hopefully decrease all those symptoms and bring the athlete back to a steady respiratory rate and able to be relaxed instead of in that distressed setting. And that athlete can use that as many times as they deem necessary. Granted, we don't want them to use that as a crutch, but we will have it accessible, and if they have to use it once and that's it, then so be it. But if they have to use it multiple times throughout a practice or throughout a competitive play, we do have that ready, and it's there for them and for them to be able to compete at a high level and hopefully at a comfortable but competitive level. Alright, so to finally wrap things up, we're going to discuss the long-term management of asthma. So this will be in our more chronic asthma formatting, and this consists of corticosteroids or long-term B2 agonists such as Symbicort, and these are performed or administered on a daily scheduled basis, meaning that it's long-term management, so we're hoping to improve over time. But with that being said, it will not combat against acute asthma attacks, because this is a long-term, which is a long-acting rather than a short-acting, which we discussed earlier. But in hopes of combating that EIB, which is exercise-induced asthma, we will continue to do this on a daily basis, and that will hopefully help prevent against those symptoms being triggered so easily and being able to play without that use of an inhaler during that acute setting. Alright, so that finishes us things off for how we're going to handle asthma throughout the sports medicine team and working cohesively with our athletes and the parents of our athletes in order to efficiently and safely look after those athletes. The sources I used was Pharmacology in Athletic Training, written by Holcomb, the assigned book. I also used some facts from the American Academy of Allergy, Asthma, and Immunology, and then I got some of my peak flow information from the Asthma Initiative of Michigan. And that wraps things up, so thanks for watching. Have a good one.